This is Dr. James Kneller. Thank you for joining us. Please subscribe to this YouTube channel and like us on Facebook. And give us feedback by leaving your comments.
Technical glitch, you should have worked that out in advance. So once again, welcome to Priest Lake. We love Priest Lake. Thank you to Biotronic for sponsoring our conference. Wayne Butler is a local expert on Priest Lake. I'm becoming an expert on Priest Lake. We love it here. I spend a lot of time thinking about electrophysiology here. And because I spend a lot of time here, whenever you have time to think, that's what you think about. So, and this is a great meeting to think more and to socialize and share ideas and knowledge and cross-link. And I've benefited tremendously from this conference over the years, and I hope that you do too. And like I said before, it's about interaction. So if there's questions or comments, please jump in. Certain speakers like Tim Lismeyer are very interactive with the audience, so I'm learning from him and try to be the same way and sort of anticipate that and be ready to be involved. In addition to Biotronic, we have a number of sponsors who are supporting our meeting, and we're thankful for those. That's Janssen Pharmaceuticals, so Brent Decker is here, and his partner Tammy. Also Sanofi with Sean Cunningham, and Circa Scientific, Valerie Meyer is here. And so interesting, Valerie represents Circa. We're trying to get her into our lab. Her father is Dr. Ironside, who will give our next lecture. He's a pulmonologist in Richland. So a bit of a family affair here. So I'll start with our first topic. And this is a very interesting thing for me. I was sort of tasked with giving a presentation on this topic, and it was a good chance for me to wrap my mind around the pocket space or the device envelope space. So we have BioEnvelope to improve the CIED pocket. Everyone knows what CIED stands for, cardiac implantable electric device, electrophysiologic device. So it's any pacemaker, defibrillator, CRT machine, SICD, all that goes under the umbrella term of CIED. So here we're talking about new biomaterials to reduce erosion and infection. And I know we have implanters here, we have very senior device clinic folks here. Many people who are familiar with device pockets. Tash is here from multiple perspectives, from being in the implant room, from seeing these patients in follow-up, and seeing these cases come to change out. So first of all, there is an increasing burden of device infections, which is disturbing for a field that should be progressing in this area. Between 1993 and 2008, there was a 100% increase in device implants worldwide, all sorts of devices. And during that time, we had a 200% increase in the rate of infection of these devices. And of course, we all know that infections are very serious, because typically if you have a device infection, the whole system has to come out. So it's very expensive. That's tremendous morbidity for the patient, and this is a very unfortunate situation. So we have this ballooning of device infections happening worldwide, and we ask, why might that be true? Well, we all know that we are treating older patients. Those patients have more comorbidities. We are now implanting more ICDs and CRT systems, so that means more leads that we are implanting, longer procedure times, and the patient's on the table, the incision site is open. We're doing more replacements, revisions, and upgrades to previously implanted devices, and we'll see that has a 2 to 4 increased risk of infection relative to a new implant. And we have more resistant bacteria. Staph aureus and Staph epidermidis are our most common offenders, and they are becoming more resistant to our antibiotics. And then I added this one of my own, lapsing sterile techniques. And sometimes I wonder if our sterile technique in the lab needs to be shorn up a little bit. You know, I'll be scrubbing into my case and have my mask and hat, and I'm like, no infection. And as I go into the room, someone walks out with no hat and mask. And, you know, it's like, well, what are you doing in there? And of course they went in inadvertently, and it's like, well, do we shut this case down and re-drape and re-prep the whole patient because of you, because we might have an infection? And of course, if we have an infection, the only one who's going to get blamed is me, and that gets reflected in my numbers. So I feel like I have this huge burden of responsibility to minimize infection, and I'm working with a lab that can be a little bit sloppy at times. It's just human. But something for us to be aware of. Devices, our procedures with implanted devices require an OR level of sterility that I think even other ORs don't always achieve. And that's because our devices, if we get infections on them, they can't clear. And so the whole hardware has to come out, whereas most operations in the hospital aren't implanting hardware. So that's much less of an issue. We'll get to all those things. So moving along, I'll just show you a couple of pockets. So I kind of took an interest in pockets as we got closer to this talk. So here's an Icd CRT pocket implanted 5 years prior. Everyone in the device clinic will have seen plenty of these. That's a beautiful scar in this 83-year-old man who has lost 30 pounds since his original implant in 2013. So cardiac cachexia. Patients with heart failure, they have refractory heart failure, they are losing weight, and he says, my ICD has definitely migrated laterally. Fortunately, there's no serious impingement. It's not pushing out laterally, it's not eroding the skin, it's not causing him discomfort, but this is something to be aware of. These big bulky ICDs that we implant often do migrate and cause issues. So something to be aware of, but that's a nice, beautiful pocket incision in a scar that has had plenty of time to mature. So here's a pacemaker pocket, post-op day 38. So you see that in device clinic? Barb, any concerns with that? So that's fine.
Days, yeah.
That's a nice pacemaker. You know, this is a scar that's forming. The black is still residual iodine from the original, chlorhexidine prep. And that scar will continue to mature, I believe, and look very much like the 5-year scar when it is completely mature. So these scars, they continue to, the collagen continues to reorganize for years following your initial implant, and that looks like a very nice tight closure with no issues in my mind. How about that one? So here's a pacemaker patient, post-op day 7, comes into the device clinic. What about these? Yeah, so she's having a local allergic reaction to the steri strips. And that's annoying and irritating, but that does not compromise the pocket at all. That looks like a very tight closure. That scar is going to continue to flatten and reorganize over time, and I'm not worried at all about this. It's annoying and a little bit itchy and irritating for her, but that's going to clear up over time. So we're not concerned. Here's an Icd pocket post-op day 12. You can see the bulkier device causing larger contours, but I would say too that device looks very happy. Nice tight closure, you know, it looks like it's sitting very comfortably and not putting any excessive pressure on the surrounding tissue, so I'm happy with that. How about that?
Looks angry.
Pacemaker pocket, post-op day 13. This is a little bit of a painful case for me. 96-year-old female, implanted with a pacemaker 1 month prior, referred to my program from an outside hospital for an RV lead perforation and atrial lead dislodgement. 96. This is her post-op day 13 following our revision procedure. She's in the office, sharp as a tack. No discomfort, there's no fluctuance, no fever, no stitch abscess, no systemic signs of infection. The patient's happy. But it kind of has that look. Anyone concerned?
Yeah.
You think that's infected? So here's when she came to us, the atrial lead has fallen, the RV lead is through the ventricle. You can see the leads down in the atrial lead is certainly down on the x-ray. This looks suspiciously low. Here's the lead on echo, not going parallel to the septum where it came out through the RV wall. So I collected a few images because we paid attention to this case. We had cardiac surgery on standby, everybody, blah, blah, blah. So, you pull back, you reposition, and fortunately nothing happened. The heart's a muscle, it squeezes, so when you pull a lead back through the myocardium, it's squeezed shut, and that's usually what happens. But after a month, you wonder if it's kind of fibrosed around there, and maybe it's not going to do that. So you need everybody ready and waiting, and everyone was ready and waiting. Fortunately, nothing happened. So we repositioned her pocket. Every check if the device has been functioning fine, but anyway, you wonder about that a little bit. And so we're going to watch and wait. We'll give that another few weeks and keep checking on her. But I really do, pictures can be very deceiving. I really do expect that to heal up. And this sort of bruising around here, that's her second pocket manipulation in a month. I don't like the looks of that color, but it doesn't doesn't feel like it's impinging. It's not a tight pocket. I think that's, that's bruising from a couple of recent procedures, and I really do think that one's going to clear up, and I certainly hope it does. So pocket infection. We're always playing these games, looking at pockets and trying to guess if there's having problems. So here's some published results. Evidence is a pocket infection. Evidence is a pocket infection. You see a pocket, is it infected? So indolent swelling, here's this bulge. This turns out by this publication from several years ago to be an infection. This is a very ominous sign when there's adherence between the skin and the underlying device. You can see how it's a little bit puckered here, so they're kind of stuck together. That's particularly ominous. And of course, if you get this late where there's imminent risk of perforation or frank perforation, obviously that's infectious. This is unacceptable. And once this has happened, the device is seeded with bacteria, and there is no chance of clearing that infection, even if the patient's not acting like they are systemically infected in any way. So here's another one from the literature, evolving over 2 years. How anyone let this go for 2 years, I'm not sure, but we get these images. So here you see that adherence of the device to the skin. That's already infected. And here you start to see the skin break down, and then more breakdown and pus, and then finally frank erosion. So all evidence is a pocket infection, and time to get very concerned right about here before the skin breakdown starts to occur. So we have infection rates, and that can vary with the definition and the follow-up depending on the study, the rate of infection that's reported, but large studies have sort of shown us that pacemaker infections risk of 0.5 to 1% over the first 6 to 12 months. And then if that's an ICD, that infection rate reported to go up to 1.7% over the initial 6 months. CRT, according to some of these references, high as 9.5% over 2 years. And that seems too high to me. I have a hard time intuitively believing that that's correct. But let's appreciate that as we get increased devices and complexity, we increase infection risk. Higher risk if that device is implanted at thoracotomy, so that's by our cardiac surgery friends while they're doing other things. Higher risk of infection statistically. And after device replacement, upgrade, the infection risk is 2.4. So when you go in for that gen change, someone just threw a gen change on my schedule, no problem. Gen changes are easy. We have to be aware that our sterile technique needs to be impeccable because this particular procedure has a 2 to 4 times time infection risk as a de novo implant. And if that person with chronic hardware gets infected and that entire system has to come out, finally something that's very routine and easy has become extremely difficult and dangerous for the patient. So those change outs are exceedingly high risk, and if we do procedure device upgrades, we really need to be able to justify. But it's really the staff that give us the most problems. And we have barriers to preventing and treating infections. Like I alluded to earlier, the devices we implant are avascular, so they can't mount an immune response themselves. They're not able to transport antibiotics to their surface to clear infections. And when we implant these devices, and we'll show pictures of these, the body builds this avascular tissue capsule to surround the device. So the body says, I don't recognize that pacemaker, so I'm going to make a capsule and just surround it, wall it off in a cocoon so I don't have to think about it. And so all devices, pacemakers, loop recorders, ICDs, live in these avascular tissue capsules, and that's the body's natural response. And we want a nice capsule to form because that means the device is held in something snug that has structural integrity, and that should be protective over time. We have bacteria that form biofilms, so they're protected from antibiotics. So the bacteria living on the device, and they cover themselves in goo, and antibiotics can't reach them because they're hiding behind their biofilm. And as soon as the antibiotic is gone, they can reactivate and reanimate and cause an active infection. So then you can ask a question, would a device envelope, say impregnated with antibiotics, be beneficial? So now we're going to coat our device with an envelope that's soaked in antibiotics, and is that going to be beneficial in preventing these long-term infections? Or would a vascularized tissue capsule be beneficial? What if that tissue capsule actually had a circulatory system and could deliver immune cells and antibiotics right to the device surface? So all those are possibilities, and of course, just to remember the evolution of resistance of Staph aureus, we had simple Staph aureus in 1950, sensitive to penicillin, then penicillin quit working, so we had to use methicillin. Then we all developed MRSA, everyone's heard of MRSA, and vancomycin bailed us out of MRSA, created vancomycin-resistant enterococcus. And finally now we've discovered vancomycin-resistant Staph aureus, which really leave us up the creek with no paddle. But this is out there, although mainly in the real world we're still contending with MRSA. So bacterial infections, again, like we said, are serious. So here is risk-adjusted mortality rates for patients with devices. So if you have a pacemaker, your risk is 1.5. If you have an infection, your mortality rate spikes up to 8.2. And the same is true for ICDs, CRTs. Interestingly, CRTPs were particularly dangerous for reasons I don't understand. 1 year mortality after a CIED infection, it's estimated at 20 to 60% depending on the series. So when our patients do get infected, because of these, there's a variety of reasons, but when it's due to our lapses in sterile technique during our procedures, we have to realize that we are subjecting our patients to considerable harm. So just a little cartoon, there's the bacteria. He lays down on the surface, covers himself with goo, and the antibiotics can't reach him, so he's protected. Staph aureus are notorious for that, having these biofilms. So once they get on your device, there's absolutely no way to get them off the device because they're always hiding behind films. Maybe our clinical pharmacologist who's in the room or pharmacist might have some comments on these things, but that's certainly my conceptual understanding that I use on a practical basis to think about device infections. So antibiotic prophylaxis. We know that prophylaxis with antibiotics lowers infection rates. Staph is most common, so our IV antibiotics should at least cover staph species. These days, almost 50% of staph species are MRSA, methicillin resistant. So then are methicillin sensitive Staph aureus coverage sufficient? Most of our device implants are prophylaxed with Anseth if the person doesn't have a pen allergy, and that does not cover MRSA. And if someone's allergic to penicillin and we don't want to bother with vancomycin, we might just give clindamycin. We have no clear guidelines when to cover for MRSA. So usually if someone is known to be MRSA a carrier, or they've had a previous MRSA infection, then we always use Vanco. They're not actively infected now, so do we need to be doing that? Is it helping at all? We really have no guidelines at this point for what to do. Some studies have suggested to continue antibiotics for 5 days after the implant to perfuse the pocket while it's still fresh and there's circulatory access to the pocket, probably to minimize bacteria that may have inadvertently arrived in the pocket at the time of implant. So that extra 5 days, nobody wants to cover 5 days in hospital for antibiotics these days, but it might be a prudent clinical decision. And that leads you to the question, how about delivery from a device envelope? If you don't want to do this, maybe should you have a device envelope that is delivering antibiotics? And that has clearly been demonstrated to be effective. And you wonder, should it be standard of care? And we'll look at some of that data as we go along. So here, this antibiotic resistance to avascular tissue capsule. And these are some pictures we snapped during some of our generator changes, just to give everyone a sense for what we see when we go into these pockets. What's inside the device is here's the pacemaker, and we're going to swap that out. And this tissue is what the pacemaker is living in, and that's this avascular collagen capsule which surrounds the device. We cut it open and basically put the new device back in the capsule and sew the whole thing shut. So it is, we have a non-vascular device in a non-vascular tissue capsule. And the issue is what to do with this capsule, and that's a question in our field. We have isolated Staph aureus from uninfected capsule tissue. So if you dissect out this capsule and you send it to a microbiology lab, they can isolate Staph aureus from within that capsule. So what happened was, when you implanted the device, Staph aureus got into the pocket, the capsule formed, the staph are now living in the capsule, they're quiescent, they're not actively generating an infection, but they are live and well inside that capsular material. And you're like, well, that one was good enough, ha ha ha, our sterile technique was fine because there's no active infection, but in fact you let bacteria in there and they're living in this. So then you say, if that's the case, that bacteria actually live in these things, should we have a vascularized capsule to reduce infections? Because then you'd have the chance to mount an immune response from within the capsule if that actually had blood vessels in it. And here's another one from a CRT gen chain. You see this thick capsule material, and that can be 1 or 2 millimeters thick. It's really thick. And if you have leads that are entrapped because you need to swap out leads, you can spend a lot of time dissecting out this capsule tissue just to free leads. And to get down to your suture sleeve, so you can cut the ties on suture sleeves and free that lead, you can spend a good hour at the start of your case really trying to do that. And this is when we get into these new methods of cautery, like the plasma blade product, for example. You can cauterize right on the leads, much less trauma to the leads. You can pretty much bovie on your leads successfully to free them. That's much better than a standard RF bovie. So we always want to use those products when we do these gen changes. If you damage a lead in this process, now you're really in trouble. You have to, are you going to get vascular access? And you're going to replace that lead? What are you going to do with the old lead that you damaged? And you raise all these other issues if you damage leads, all because you're trying to work around this avascular capsule. And with these large devices, that capsular material really is significant. So the question is whether or not to perform capsulectomy at the time of your device change. And there's arguments both sides. So should we? Uncertain benefit during a generator change, whether to take out the capsule. It can be argued that you help revascularize the pocket, allowing antibiotic penetration if you cut out that capsule. If you cut out that capsule, you're probably going to nick muscle because they're so adherent, and that will almost certainly increase bleeding, may give you a hematoma, may release bacteria that are living within the capsule. So just by cutting out the capsule, you release bacteria that are now in your device pocket and are able to cause an active infection this time around. Larry Epstein, senior electrophysiologist at the Brigham and Women's in Boston, our practice is to perform a partial, if not a full capsulectomy to vascularize old pockets that change out. So their practice, if they can get away with it, they want to err on the side of capsulectomy. So an interesting opinion piece. Certainly not routinely practiced and not something that's well defined. So let's move on to another source of infections, pocket hematomas. And here's a paper kind of calling for a uniform definition of the pocket hematoma because these can have tremendous variety. So I'll just look at a few of these. Here's a large ecchymoses, and what did they say about this one? No effusion, pocket was not tight. This kind of clinical phenomena does not require therapeutic interventions, just watchful waiting. How about that one? Large effusion. The large effusion disappeared after 10 days and caused 2 outpatient visits for pain medications. Because you're stretching the skin's very sensitive, so these things hurt. So they said, we're just going to manage pain, but that thing did resolve after 10 days. Here's a small effusion requiring no intervention. Here's a large effusion. This large effusion was very painful for the patient, required reoperation for hematoma evacuation. So because it was so painful, they had to cut in there and empty that hematoma. And while you're in there, again, you want to make sure that your active bleeder is no longer bleeding. So we see these hematomas, and we all want to watch and wait to hope that they disappear on their own and don't cause issues. Pain is a problem. You wonder if your sutures, which are actively resorbing, are going to last long enough to allow the hematoma to resorb before the sutures burst. So I always tell my device techs who are learning to close pockets for us, you need to close this pocket expecting the nurse to give this patient heparin tonight, and there's going to be a huge hematoma tomorrow morning, and you're labs. If you want to grow bacteria, what do you put them in? Blood as a culture media. Bacteria love to go in blood. So that's what microbiology labs will use to grow their culture media. So obviously the hematoma represents an ideal place for bacteria who may be present to proliferate. So a little bit more on that. Hematoma is not on antithrombotic medication, 0.9%. Aspirin is said to carry a 1.5-fold increased risk. We never hold aspirin for our device implants. Dual antiplatelet therapy, aspirin and Plavix, I never hold that either. 5-fold greater risk. Okay, in one trial, risk of hematoma between aspirin and an oral anticoagulant, that would be warfarin. Similar, but on the order of 5%. I have a hard time believing that, but warfarin, a 5% risk of hematoma there. And then we recognize that heparin products, evil molecule heparin, markedly increases our risk of pocket hematomas. Fewer hematomas for implants on therapeutic warfarin versus bridging with heparin. For some reason, pockets bleed when there is heparin given after the case. For patients who are low thrombotic risk on warfarin, you're not going to stroke because you have infrequent AFib, but you indicated for warfarin anyway. Then in those situations, just hold the warfarin and don't implant on it, and don't take the risk. So tips that we can do during our implants: ensure complete hemostasis. Okay, and that means not staying within the fascial plane when we create our device pockets. You never want to cut into the pectoral muscle because muscle bleeds, and it's hard to stop that. Consider hemostatic agents like FlowSeal, robust pocket closure, 4+ suture layers. Ensure no heparin products, and that includes that DVT heparin 5000 BID that everyone wants to be on the medical floor and everyone thinks is indicated. Don't do it after your device placement. Maybe we should leave our patients in slings for longer, ask the patient to minimize motion and avoid any trauma. If there is a hematoma, we want spontaneous resorption, which is preferred over cutting open and evacuating the device. And again, we ask ourselves the question, would a vascularized tissue capsule help to resorb a hematoma? Possibly with this BioEnvelope that we'll talk about. And would local antibiotic delivery from a device envelope be of benefit in the setting of a hematoma? So less chance of bacteria, which may otherwise thrive in that hematoma, from becoming active and causing infection. Another issue that we do face is this business of device migration and pocket erosion. And again, here's another case from the literature where the procedure incision is here. That's the scar. So usually the device is right below the scar. Now the device is beside the scar and sticking out. So that has migrated, and as a result of migration, subsequently eroded. So another sad situation. And here is pocket erosion without migration. So this is a device that's way too superficial. You can see it sitting in the skin layer. And we have frank erosion at several places. And so now that device is hopelessly infected. There's no chance of clearing that. So that's unfortunate. So how can we address migration erosion? We should put our pulse generators directly on the pectoral muscle at the time of implant. These superficial subcutaneous implants just under the skin are painful for the patient, and their structural integrity is quite low. And I find myself as an EP, I'm a general cardiologist, I'm an interventionalist, and I do pacemakers, okay? We'll end up revising devices for those folks. I've had to do a fair number of those in my career, and often it is because the device is just way too superficial, and that's sort of especially true envelope that's available, which is TYRX, and we'll talk about the difference between those two. But all these things that we can do to improve our implants, improve our chances of success, minimize the risk of infection. And again, one final tip, we'll get going here, but implant only necessary hardware. So do you really need a dual chamber device when you could be using a single chamber device? That's particularly true with ICDs in patients who have no pacing indication. We should be using single chamber ICDs. And interestingly, Biotronic does have the ICD with the DX lead, so at least you get atrial sensing from your single chamber ICD lead. And that's a nice technology which helps us get more for our money aghast at what she sees. And for Tash. So, pouch technology. Who knows how many pouches or device envelopes are out there right now?
Two?
There's two. So this is something that I had to clear up in my mind for a couple of reasons. Is one, I have run into surgical sutures, and this is a resorbing polymer, open pore weave, knitted filaments, impregnated with a combination of minocycline and rifampin, so two antibiotics, bacteriostatic and bactericidal. And we'll show you why those are good choices. That's what it looks like. Here's a little bit closer up the weave. This is said to dissolve completely within 9 weeks. Came up with this risk scoring system for your risk of infection based on patient factors. And as patients become high risk for infection, their chances of benefiting from the TYRX envelope go up. So the higher your risk of infection, the more you benefit from having a pouch. And that was an interesting result, and again, one that's probably somewhat intuitive, but we really resorbable antibacterial envelope that they are going to market. And we did a gen change with Medtronic the other week. They brought their pouch, said sure we'll use it. And so you soak it for 30 seconds. They want you to flip it inside out because the edges are a little serrating. So we flip it inside out, and then you put it around the device and put it in. You can put an anchoring suture through it to make sure it stays on the device, and there it is as you close up. And this is creating a much larger technology to use for a variety of medical applications that we will see, and they're also using it now as a device envelope. So this BioEnvelope is composed of extracellular matrix that is an interstitial bioscaffold. It's used in regenerative medicine to restore and repair tissue. This material, biologic material, serves as a signal for cell migration in the heart, such as valves at the time of cardiac surgery and cardiac repair, valve repair, for example. In carotid artery procedures, serves as patching and repair following carotid endarterectomy procedures, so it helps to rebuild the artery. And then finally, the application that we're interested in to reduce complications of implantable electric devices, whether those are infections or erosions. So you can don't peel capsule, which is very interesting, and does have the potential to deliver antibiotics. Whatever antibiotic we soak the pouch in, because it doesn't come with antibiotics. So it's been tested with vancomycin. So here is Staph aureus in a bioenvelope soaked in Staph aureus. You can see it's clearly repelling the antibiotic, or